We are joined by a doctor. She's a general pediatrician. Dr. Mercy Githumbi is our guest. Good morning.
Good morning.
Welcome to Kenya's biggest conversation.
Thank you very much. It's a very wonderful opportunity to be here.
Karibu. We call that the
Yes.
hot seat of the situation room. How does it feel?
I'm starting to feel it, but we'll see how it goes.
To welcome you to the conversation, City Muga has the day's proverb. Every week, City comes up with proverbs from one country in Africa. So we look at proverbs from that country. People have been saying this week's proverbs have been the one. Today's proverb?
This one is simple. 5 words. Hunger is better than shame.
Hunger is better than shame.
Yes. Don't tax your mind. Just straightforward. It's better to be hungry than to be shameful. No, to be ashamed. Well, actually, even shameful.
Even shameful.
You know, when you're hungry, it's you who knows. Huh? And someone will know if you tell them. You can say someone looks hungry. But that look of hunger could be many things. You could just be tired. You could be dehydrated.
And you can easily sort out hunger
Quickly.
by
Shame.
eating.
Shame.
Dr. Githumbi, what do you think? This one is from which country again? Sid?
This one is for Burkina Faso.
Yes.
So from Burkina Faso, hunger is better than shame. I think my understanding of this, especially the shame part, shame is considered worse because in the opinion of the person who's feeling the shame, they might think that people around are aware of what they're ashamed of, which they may or may not be. So that's why it has a bigger tax on the mind of the person who's experiencing it. As opposed to hunger, you're the only one who will be feeling it. The other people might not notice it, unless maybe your stomach sounds a little bit there, but that happens to everyone.
Yeah.
It might be something that you're not able to control, but if it's something that is causing shame, you will start wondering what could I have done differently, or what do people think about me, which is more stressful.
It's more stressful.
Yes.
Hunger is better than shame. Good one. You're here, Daktari, so we talk about something that's, a common occurrence, bedwetting. Okay? But now we move it from children to bedwetting in children and teens. So there's a certain, so let's first of all start with bedwetting. What is bedwetting?
So what is bedwetting? In terms of medical terms, but I'll try to keep it to the simple terms, it's what we usually call medically as enuresis. So this is where a child or an adult who has reached an age where they should be dry, they starting having episodes or accidents where they're accidentally passing urine either into their clothes or even into their beddings. So usually most of the time it's been defined when it occurs in children above 5 years of age, but around that time it might not be a major concern, but it can persist and go on into older age groups, even into adulthood. So that's why it becomes a major concern. So it might have an accident once, then it is okay, but it becomes more concerning when the child starts having recurrent episodes. Yes.
What's recurrent? What are we talking about here? And how often must it be for it to be a concern?
Okay. So bedwetting can be a concern in different ways. So one of the things is it might be even just one episode in a month, but it's distressing to the child themselves, the adolescent, or even their family. You might find it's affecting their self-esteem, it's affecting their school performance, it's affecting even their social interactions. So even that one, even if someone else might not consider it frequent, it's significant to the person it's affecting. But for other terms, you might also find it significant, like if you're having more than 2 episodes in a week for a duration of more than 3 months continuously. And this should also happen in an age group at least above the age of 5 years. So that is one of the definitions. But also it can be concerning if a child who had gotten dry during the day and during the night then starts having episodes of having bedwetting coming back. So the parents might be concerned, why is the child having bedwetting again and they had gotten dry?
Is this a physiological problem or a psychological problem, or is there a combination of the two?
Okay, so bedwetting is a combination of the two. So it can be caused by different things. So first of all, you can have bedwetting which occurs exclusively at night. So you find during the day the child or the adolescent is fine. Then at night when they go to sleep, they wake up, they've had an accident, or some of them even it progresses even during the day, they can have some accidents. So it can be physiological and maybe a problem within a condition that's affecting the child. So they might have the bladder is not able to hold as much urine, so it can start leaking before it's filled to its full capacity. At times you might find that the muscles which help control the bladder, because the bladder is like a bag, they start pressing or what we call contracting, and this can cause some dribbling of urine. At times you might find, because of other associated conditions which we shall talk about later, it can make a child to start having bedwetting or passing urine on themselves. Then you might find if a child or an adolescent is exposed to any stressful life events, they can trigger the child to start having these bedwetting episodes, or if they are present, they can become more frequent than what they were before. So it has both a psychological effect and also a physiological effect causing the episodes.
Let's talk about this physio one, where you say, it could be an issue with the bladder. Is it painful?
So,
Would there be anything that would make this child raise concern? Maybe they're feeling pain. Do they feel it?
okay, so at times it might just come out, it leaks or flows without them being aware, so they might not have pain, and the only symptom is when they have wet themselves. But for some children, they can have some additional complaints or concerns with regards to their ability to pass urine. So some can have pain when they're passing urine, or pain in what we call the genital area, where the urine usually comes out or the urine is stored. Some of them might be going to the bathroom, they might report concerns where there may be straining to pass urine, or they pass urine but it's not fully, they feel like they're not completely emptying their bladder, or they keep going to the toilet very many times. You might find even more than 8 times in a day they keep going to the toilet to pass urine, so for the short call. Or you might find they go, it takes a while before they're able to start emptying their bladder, so they have what we call hesitancy. Or even after they've passed urine, they still have some bit of leaking or dribbling that's coming out. So you might not necessarily have pain, physical pain, but you can have other symptoms, but it can also be distressing to the person who is affected.
What causes these bladder issues?
The bladder issues can be caused by different things. One of the things is especially the bladder itself, and the bladder is where the urine is stored. So the bladder has a specific capacity. So you might find that the bladder is not able, so they're said to have a reduced bladder capacity. So the bladder is not able to hold enough urine, so it might leak before they are aware of it. Another thing is the muscles that usually block the drainage of urine when one does not want to pass urine. If they're not able to contract and close and hold the urine, that can cause it. Another reason can be, especially at night, your bladder, usually if you have the urge to pass urine, you should be able to start having the urge, and it might even wake you up from sleep. For some who sleep very deeply and are not able to get aroused, you might find they might have the urge, but since they don't manage to wake up, they pass urine on themselves. Yes.
So then it looks to me that then there are compartments of issues when it comes to the general bedwetting that you would otherwise be aware as a child of the need to go to the washroom, but you're you're a heavy sleeper, right? So maybe when you woke up is when you realize that you've wet the bed. And what if now you're woken up and taken to the bathroom regularly? Would you see that this now would become habitual, that you then would now just wake up even if you were a heavy sleeper? Are there things that can be done to train one? Because then now you're not looking at maybe something particularly wrong. I mean, we've seen things like people would withdraw beverages before a child of that age went to bed, so that they were not then wetting the bed at night if they were a heavy sleeper. Are those some things that you put in place, and can those work?
Okay, so some of the things that can be done, you've mentioned like maybe there are some parents who might say they're going to restrict and limit the amount of fluids which will be taken towards the evening. So that has been found to be beneficial for some people, but not, you can try it and see if it works. So ideally during the day the child can drink as much of the fluids that they can, but maybe you can say from 5 o'clock they drink maybe around 20% of what they would have taken for the day before going to sleep. So you limit the amount of fluids the child is taking. Another thing is encourage the child that if they have the urge to go to the bathroom, they go, and to try and completely empty their bladder. And also every time before they go to bed, it would be a good habit to develop the habit of taking them to the bathroom and encouraging them to pass urine so that they can empty their bladder. Some have tried waking up the children at night. It might be helpful in some, especially if maybe the child tends to pass urine once and around what time. But for some who might be passing multiple times, that might be difficult to decide this is the time to wake up the child. But you can do things like maybe putting plastic layers or Macintosh layers under the bed with beddings on top. So just to reduce, even if they do have an accident, at least it's easier to change that without it seeping into the mattress, so that even after the accident the child can be changed and go back to the bed after the bed has been remade. And also encouraging the child, if they feel the urge to go to the toilet at night, they can wake up, so you can even have some night lights, or they can come and call you to help be taken to the bathroom. Some have even said you can have a small potty because they might be afraid of going where the bathroom is, so that they can go. So those are just some of the small things that can be done, but when it reaches other stages, we can go forward and do further assessments.
Okay. Sometimes these children will get up and take themselves to the washroom. It's not every time that they may wet, but more often than not, they would wet the bed. Sometimes they'll take themselves to the washroom. Now, that action of taking themselves to the bathroom in the middle of the night, is that something then that can be worked on so that they can now do that? Because if it's a problem and sometimes they're able to go for themselves, then how severe or serious is it?
Okay, so at times they're able to go by themselves, but at times the problem can still persist. They might not manage to wake up every time. But what they need to understand, one, even if they do have an accident, they are not at fault, because at times they can get very stressed and scared. They know they'll be punished if they accidentally wet their bed. And also the parents to know it's not something they have done or not done that's causing this. So if they are able to, they can be woken just before they go to sleep. They make sure they've emptied their bladder. The one for waking up would depend on whether or not you can know when they will wake up, because also if you keep interrupting the sleep of the child, this might also not be beneficial for the bedwetting, because if they're wetting like 3 or 4 times in a night, you might not be able to wake the child. In the morning they'll be still quite tired, but maybe if you know at a specific time you can wake them up, they go, but still some might still have an accident. So you try what you can to reduce the episodes, and also you try and support them so that even if it does happen, they have tried what they can do to help reduce the episodes.
Do you have statistics are they, let me rephrase this question, of the episodes that one encounters in the normal processes of carrying out your work, do you have an idea of how many people, how many children overcome this situation as they move to adolescence and then to adulthood?
Okay.
And if so, even if you don't have the numbers, what is it that then would influence their overcoming this situation that we are discussing?
Okay, so with regards to the numbers, we found bedwetting globally, and also for some studies that have been done locally in Kenya, have been found by around the age of 5 years or so, around 15% of children are having bedwetting. As they grow older, the episodes become less. By the time they're around 10 years, you might find it has reduced from 15% to 5%. By the time they're around 15 years, around 1 to 2%. So that's like 1 or 2 in every 100 children are still having the bedwetting. So it's like every year the prevalence or the number of people who have in the bedwetting reduces by 15%. So majority of them eventually outgrow it. It takes time, but depending on the number of episodes. For example, one who's having infrequent episodes will be more likely to overcome the challenge and much faster compared to someone who might be having it frequently, like every day or every night is having an episode of bedwetting. So it gets less as they grow older, and that is something they can have hope for, that for majority of them they will outgrow it.
How then do you deal with the situations where people carry on this to adulthood?
So by the time you're having these concerns of bedwetting, it would be good, one, to be reviewed by a medical practitioner or your doctor. So at one, we can try and find out, is there any underlying condition or disease that's causing this bedwetting, or is the bedwetting not secondary to anything else? There are some habits and also management of stressors that can be done. Some we've already mentioned, like for restricting fluids in the evening for those who it helps, but during the day they're encouraged to take as much fluids as they can, encouraging them to completely empty their urine, having the habit of voiding fully before they go to bed in the evening, waking up at night if they have the urge to pass urine, because for some of them, if they are fearful of waking up at night, they might hold it off. Then also at times, if they are stressed, you might find if there are some stressful life events occurring, someone who didn't have the episode can start developing it. But for those who are reviewed in hospital, there are some who even some medications might need to be started if and when it is warranted.
What are these other causes of bedwetting? You said, so we got the physio, and then we've got the psychological side. You said if there's something that is stressing the child, it could manifest in bedwetting.
Okay.
What are these things?
So you might find in children, maybe if there's a new child who's been born, so now their older siblings are big brothers and big sisters, this is a new change in the environment which might manifest because they are yet to adjust to the new environment and the interactions in the home, so that can trigger. Some of the other stressors that can be there is maybe if there's any loss in the family or maybe any parental separation. Also, you might find that if there's any bullying that is happening either at school or even in the home, or any abuse, so anything that can contribute to stress, this can also contribute to the bedwetting becoming more frequent or even starting at that point.
When a child comes to you, when the child is brought to you and you maybe they've even come on something completely different, are you able to detect some of these things? Okay.
For some of them, you might detect them because they might have maybe the smell. You can sense the smell of urine. Some of them, the parents might even communicate to you that they're having this additional concern where they're bedwetting. So that is one of the other ways that you can have that. Then also at times you might find, because of, especially if there's frequent bedwetting, they might have some irritation in the genital area because of the leakage of urine that's irritating in that area.
So what do you do in such cases?
Okay, so when you have such child or adolescent or person in front of you, or what we try and find out is, when did this bedwetting start? How frequent is it happening? Are they having any extra or additional symptoms other than the bedwetting, the ones they had mentioned earlier? They go to the bathroom very many times, they're straining to pass urine, they're not able to completely void, they're having pain anywhere. You find out if they're having symptoms that can point to other conditions. For example, someone who was completely dry, then they started wetting themselves. Then you see maybe they say they're drinking a lot, passing a lot of urine, even they're losing weight. You can think of diagnosis like diabetes, which can contribute to this. You might find some children, you're being told that they're chronically snoring. You see most of the time they're breathing through their mouth because their nose is blocked, something that we call obstructive sleep apnea. So for those ones, they might also have episodes of bedwetting, and when you deal with the underlying condition, condition, it will settle down. For some of them, you might see when they're walking into your examination room or in your office, how they walk is a little bit different. Or when you examine them, you see at their lower back where the spine is, you're seeing something that is different from what it should be. You start suspecting things like conditions affecting the spinal cord, things like constipation. It's quite common, but it can also contribute to bedwetting, because when they are constipated and they have a lot of stool in their stomach, in their abdomen area, the bladder is not able to hold as much urine as it should be able to do that. And for others, they might just have what we call bladder instability. The one was saying that the bladder keeps contracting, so they keep emptying the urine. During the day, they might manage to go to the bathroom many times, but at night, it can manifest as bedwetting. So there are quite a number of other additional conditions which might have with this as the symptom, and other, when you just examine the child, things that can contribute to them having this.
Actually, does it end after teenage?
So with regards to ending as the children are growing older, the episodes become less and less. So for majority of them, they will outgrow the condition. But for some few, it might persist for longer. But for when it reaches that situation, it's where they need to be reviewed and assessed, and they might need to have some medication or other medical interventions put in place. But for majority of them, they do outgrow it.
You know, the psychological aspect of bedwetting is what's actually on my mind. The proverb today dealt with shame. And it looks like the predominant emotion in this particular discussion is shame. One feels ashamed that they have wet the bed. Now, would diapers help? Because the advent of diapers, we moved from children to adolescents to adults. Because with diapers then, even if an episode occurred, the damning evidence
would not be there.
Yes, would either not be there or would be limited extensively. Yes.
Okay. So shame is one of the main things that usually concerns them. The psychological effect, people knowing that this happened, especially in the adolescents, children who are in boarding schools, at times even at home, so they fear they're going to be, or even not just fearing, they are actually bullied or even shamed, or people talk about it, and this gives them more stress. Diapers in themselves, no specific evidence, that is what I would say, is recommended for them to routinely wear diapers, especially for let's say the younger child. You might find if they have a diaper, they might know, because I have this in place, I don't have to wake up if they have the urge to go to the bathroom. So they might continue passing into the diaper because they know since it's there, I can empty into that. But for the older ones, it would be better if they're able to wake up, they can wake up and go to the bathroom, and the Macintosh has been put in place. Some have actually used diapers so that, because some accidents you're not completely able to wake up and it still happens, or even some bed linings which can be changed. So diapers not routinely recommended, but some may use them just to reduce the soiling of the beds, which, because everyone will know, and the neighbors, they say every time they're taking the mattress out, and people do not want such things being shown.
Of the cases that you've encountered, is it the parents who come, that is in children of course, who report the matter to you? Or is it something that just comes up in conversation? And if that is the case, as medical practitioners, do you walk parents through the possibility of this occurrence and how one would best deal with it if it did occur, just as a matter of routine when parents come to see you? Which is which?
Okay. So it comes both ways. There are some who come specifically because they are concerned by this age the child should not be bedwetting, or even the adolescent. So what is possibly causing it? What can we do to help? But there are some who come with other problems. Then when you probe deeper, you'll actually find that has come up. Most of the time it's the parent who's more concerned. The child might hide because they are fearful or ashamed of what might be thought of them. There are people thinking that they're not doing enough to try and stop this. But it can come both ways. You might find out as extra information as you're querying, or it might be even the primary reason why they have brought the child to be seen in hospital.
What kind of therapy do you then subject the patient to?
So the therapy is usually what we call in two prongs. One is supportive, things that they can manage to do at home, support and counseling, because at times it might actually significantly affect the child, lower their self-esteem, and make them feel low about themselves, and even in future, especially if it persists, can contribute to things like depression. So counseling the parents and also the child with how to deal with such episodes when they occur, so that the parent or even the guardian doesn't get angry, because at times that might also contribute to stress for the child. Let them both know that it's not because any of them did anything wrong or didn't do anything. Telling them about habits that we have already talked about that they can do at home, assessing and investigating for other possible causes, including like maybe for some of them even check, as I had mentioned, things like constipation, even infections of the urinary system, something we call urinary tract infections. Those ones can contribute to bedwetting. So that's also some things that we can investigate and see. Talking to them about how to maybe having diaries, so that one, we can see the trend of the episodes, and when you're putting an intervention, you're able to follow up to see if it's improving. If they're still not improving, we can also refer them to specialists. For some of them, they even started on some medication when it is needed to help reduce these episodes of bedwetting.
At what point would one, as a parent, then think that it was necessary to come in to see a doctor? And even before that, what are some things that can be done at home to help with the situation before that comes into play?
So some parents might be prompted to come to hospital, especially maybe if they have two children close in age. They find the younger one has already achieved dryness, but the older one is not achieving dryness. You might find that's a reason that prompts them to come. Some might be delayed because the other sibling had bedwetting. It progressed until they were older, but it eventually cleared. Or even they themselves, as the parents, had this bedwetting when they were younger, and they eventually outgrew it. So the timing usually depends. Also, if it is distressing to the family and the parents, because for some of them they might not find it as distressing, so it might not even be they might not consider it a concern. But the more distressing it is for them, the more likely they are to come to hospital for the child to be reviewed.
You mentioned something that piqued my interest. A parent may think, I went through the same thing, so if my child is going through the same thing, they'll overcome. Is it hereditary?
Yes, there is a genetic component to it, or what we'd call a hereditary component to it. You find that if one of the parents had bedwetting, there is a 50% probability of the child having bedwetting.
50%?
Yes, so around 50% of children who had bedwetting, one of the parents had.
If both parents had?
That's around 75%. And you might find in 15%, no one else in the family has it. If you have like maybe twins, you might find if they're identical twins, if one has bedwetting, the other one is likely to have it. Compared to the ones who are not identical, it might be a bit less. So there is a genetic component that has been identified to contribute to this. But irrespective of the cause, generally for the management of all of them tends to be roughly overlapping.
The same.
You've mentioned several times that at some point for the majority of these children who start bedwetting, and then that they will grow out of it, or that it will come to an end. Does it just phase off, or is there something that happens that say, okay, well, does it now click in their heads, or are they then able to wake themselves to go to relieve themselves at night? What happens? Is there a process of events? And if something was happening that made them do this for this long period of time, and then after some time we just see it disappear, is there something that happens that triggers that to stop?
So for some of them, they can outgrow it because of how the nervous system is maturing, because that's one of the factors that contribute to the bladder control. Because you might find the ones who have also delays in other milestones, they might have delay in this milestone. For some of them, when they have been reviewed in hospital and they are found maybe to have like what you call the bladder instability or the muscles which help prevent the urine from draining at the outlet of the bladder, some of them are even sent for therapy to help increase the strength of what you call the pelvic floor muscles, so that when they have the urge, they're at least able to hold the urine, so that they can manage to go to the bathroom and empty their urine. For some of them, because the bladder is what we are calling is overactive, it tends to contract and keep emptying the urine. In addition to the pelvic floor muscles, those are some of them who can benefit even for some medications which help reduce that overactivity of the bladder, and also by treating the underlying conditions. Maybe if they have infections of the urinary tract systems or their urinary bladder, you might find if you treat that, the problem will resolve. If they're constipated and you treat that, you might find they also have resolution of the symptoms. At times, if there's any stressors and you deal with those stressors either at school or at home or even in the community, it can help slowly reduce this. So this, in addition to the ones who just outgrow, it's like they learn. The muscles and the nerves learn with time. That one will eventually happen for majority of them, although even if it is not all.
Why would a child be so aware during the day that, well, I mean, I guess this is because we're talking about, we're talking about the same nervous system. It's the same one during the day. It's the same one at night. I don't think it changes.
It's the same one.
So even though they're in a situation of being awake, why would the system be aware that it is time to go, but even at night, even though you're asleep, then I know that everything is kind of dulled down when you're sleeping, but then how would you then be able to translate? Doesn't a child who does not have a problem going to the bathroom during the day, they could be in the middle of play, they can stop, they can go to the washroom, come back and continue. But then at night, the same system doesn't allow them to perform the same action. Why is that?
Okay, so this happens in some different ways. One of the ways is usually there's hormones which are produced in the body. And then at night, one of the hormones is usually reproduced at a smaller volume, so that you have less production of urine. For some children or even some adolescents and adults, the level of hormone of this hormone produced during the day and the night is the same. So even at night, you might find the urine amount that's being produced is increased. Then too, the other one that I had mentioned was arousability. Ideally, when your bladder starts contracting, you're almost aroused to wake up to go to the bathroom. For those who sleep very deeply, you might find they're not able to become fully aroused, so they start draining or passing urine before they are fully alert. And also at night, you should have coordination, so that even when your bladder is contracting, the pelvic floor muscles or the muscles at the bladder neck should ideally contract so that it doesn't empty, so that the urine is left in the bladder. So at times, if those muscles relax a bit, even if the bladder is not filled to capacity, that small volume might still leak. So it's most of the time the arousability and deep sleep contributes, but there's also other components including the hormones. And also you might find children have been playful, doing a lot of things during the day. They're dehydrated, they come the last 2 to 3 hours before they go to bed, they drink lots of things, they take lots of caffeinated or even sugary things. In our Kenyan community, we are used to taking a lot of tea, which also has some caffeine, but also all these things can promote production of more urine, so it can contribute to them passing more urine at night, because they drink a lot in the evening, the last few hours, and you might find they didn't take as much during the day, and lots of sugary and caffeinated drinks also.
So you doctors have competition in this one big doctor that's called Dr. Google, and parents will now go to Google and say Google says this, and then they'll come and form their harambe of Dr. Google trained parents and have solutions as to what should happen. So some questions coming in already, and folks have already heard about medication. Give your child this kind of hormone treatment or supplements. Does this even work? Is this even a possible thing to do when it comes to bedwetting as an issue?
Okay. There's no specific hormones or treatment that should just be given without the directions of a medical practitioner, because one, we need to first find out what is contributing to this bedwetting. And most of these medications, majority of the patients might not need it, but for those who do receive the medicines that are necessary, it's under the guidance of a doctor. So at one, we assess, is the dose appropriate? Is it effective or not? Because for some, you might still start the medication, but it's actually not beneficial to them. But going and saying you saw this medicine work and bought it over the counter, that is not a recommendation. By the time any medication needs to be started, it would be highly advisable for the child or the adolescent to be reviewed by a doctor. At times, even where it is necessary, there is referrals to what we call pediatric nephrologists, urologists, or even other specialists, depending on what the underlying cause is, so that we get the proper treatment and the best outcome for the child.
How do you treat cases where your patient is in boarding school and they need to come see you and they're going through what they're going through in boarding school?
Okay, so one of the things is this forum is an important forum, educating the public so that they know this is a common problem. It affects many people. It's not the fault of the person. So people should not be punished or shamed, because you might find even in schools this is happening, which contributes to additional stress, which affects the child. Other things is if they can have support, like for the Macintoshes, maybe extra bed linens, so that if they do have accidents, they are able to do that. Also to encourage teachers, and also like in dormitories, because it used to be once you're in the dormitory and you're in bed, you can't leave. Even if you have the urge, and for someone who has this condition, it would be beneficial for them to go to the bathroom. During the day, especially even like in the smaller children, they have to wait till specific timed breaks, which will not be beneficial to them. So even at times you need to communicate to the teachers. If the child has the urge, let the child know they can ask for permission to go to the bathroom, and let the teacher be willing to give them the permission to go to the bathroom, because this can also contribute so they don't develop habits of trying to hold urine, which can also make the situations worse. And for the ones even like in boarding schools and in the older ones, it reaches a point once you've assessed and seen other possible causes and ruled out, we at times need to start the medication to help reduce this.
Have you ever had to deal with a case where one of your patients is in boarding school and then now you have also to deal with the school administration? To speak to them, for them to understand their student, so that then the student is facilitated, like you're saying?
Yes, such situations have happened. So at times you even need to write maybe a note to the school.
And you give the child to take?
Yes, so that they can be taken to school, so that they can be able to be facilitated. But also just, this is for the one who's come to you. How about all those many others who we have not seen and managed to write that note? So that's why the teachers and the public should be aware of this, so that they are supportive of them.
Then that calls on the Kenya Paediatric Society.
Absolutely.
So what do you do to increase awareness about this? Because, I mean, you're talking about people who are at a very vulnerable age, and then they've got to deal with this, and it's something that they have zero control over, limited control over this. They're battling it. But everybody else will treat it just like you said. It's going to lead to bullying. It's going to lead to being ostracized, which will contribute to making the condition worse. The school administration, if the head teacher and the other teachers and the other school staff do not understand what is going on, then you're not helping. What are you doing as a professional body?
As a professional body, I think there's still a lot of room for things that we can do. Community education is one of the main things. These forums, discussions on such, like at Spice FM, what we are doing now, is an important part of educating the public. Hopefully there are some teachers and head teachers and parents out there who are listening to this, so that if they do have these concerns, they have opportunities even maybe to talk, have health talks in the school. Because at times if a school or even an institution wants to approach maybe a specific health facility and they need some advice, that is always open to have that done. But also, as the parents, if they have any concerns and they need such notes put in, we do it for this, or even any other concerns which are relevant, such communication is made to the school. Yes.
I shudder to think about if this information not being shared and some of the other things that we hear happening in school, and then something that can be so detrimental to the psyche of a child in this manner, and then going to school and having episodes of bedwetting and there's no support for them. And I mean, we've heard stories of children even being beaten, having to face punishment because having wet your bed when you're in high school. I mean, terrible stuff. So it just seems that if we're talking about as large a number of those who would go into teenage years having episodes of bedwetting, then a lot more needs to be done in terms of information sharing, because quite a lot of these children are going to boarding school, you know. So is it something that can be more elaborate in terms of sharing this information, to understand that it's not just a child wetting their bed for lack of anything else to do at night? It's, you know, it's not something that they can control. And then how you deal with that child after that is extremely important for their mental well-being even.
If I may just add on to what you've just said, let me just tag on to it. The Kenya Paediatrics Association has membership that traverses all these counties that we have. What stops the Kenya Paediatric Association from partnering with the bodies that primarily look after primary schools, so that you craft a program that periodically the doctors who are in those respective areas and who are your members can actually this very same information that we're talking about, so it becomes something regular. Call it a health talk, call it whatever it is you want to call it, but there is that periodic information and information passing along so that it is known. Then the Kenya Pediatrics Association can say, yes, we have partnered with this association of primary school teachers, secondary school teachers, and there's a program we have for them to ensure that the members, which are the schools and the heads and the teachers and the students, know about these things. Because in a public forum, in a school, when such information is talked about and an opportunity provided for questions to be asked, you begin that journey of informing people. And it won't begin and end with bedwetting. It'll continue with very many other things that are specific to this discipline that you are part of.
Yes, that is a very wonderful baton to be passed on for the Kenya Pediatric Association to do so. Also, in different hospitals, there is the public health sector, and they usually have also sessions and also opportunities to interact with the publics. You've heard they usually have like sittings with the community and they talk about different conditions. At times, even when medical camps are held, maybe in some schools or some churches, these are also opportunities to create awareness with the people. Then also with these linkages, it would be a good opportunity, like things, the Ministry of Health and the Ministry of Education. So at such programs dealing with common conditions can be carried out for community education. People know when to seek help, where to seek help, and also the appropriate support, so that we have the best outcome for our children who are the future of our country.
You know, the Kenya Pediatrics Association, I know, is one of the few medical associations that allowed membership of people who are actually non-doctors. Now, meaning anyone who is involved in one way or the other with a child can actually be a member, whether you are a medical practitioner or a parent or Now, an association that is far-seeing should not stop there. Create a program that has regularity and something that one can plug into and know. On this particular day, we have this session with these people.
And this is what we're doing.
And this is what we're doing. And this is our plan for this month or for the year and for whatever. So you actually become an integral part of the learning process for the teachers as well as for the students.
Yes.
Who are the teachers are parents and the students are the clients, and there'll be future parents. Dr. Arwi, thank you very much for joining us today.
Okay, thank you very much. I hope it was informative. If you're having that problem out there, know you're not alone. There is help available, there is support available. So it would be good if it is a concern to be reviewed by your doctor and appropriate advice and care given. Thank you.
Asante sana. Dr. Mercy Githumbi is a general pediatrician. She's been our guest this morning talking about bedwetting in children and teens.
This is the Situation Room, the only way to start your day.